welfare, safety, and security to everybody that's involved. Our patients continue to come here because we provide this. You all may not pay attention to it a lot, but your patients, our patients, they stay here because we do this. Now, I do know that there are times that patients make it difficult for us to do this, but this is our job, to make sure we provide the best care, welfare, safety, and security to all individuals involved. Man, if we pay attention and look at this little drawing, there's precipitating factors that happen in our patient lives. There's also some precipitating factors that happen in our lives that we both can't control. And here's an example. We can't control if the patient's family abandoned them, if they have traumatic experiences that happened in their past. We can't control that. We can't control the things happen in our lives. However, what we can control is the integrated experience that we have between each other. So what does that mean? That means I'm responsible for patient A as well as patient A is being responsible for me. So I want you all to think about this. If we have a code, if we have a medical emergency that involves staff, who's normally the first person that sees the code? A patient, right? So what happens if the integrated experience between the patient and ourselves is broken? Something happens to you, that patient just go get their lunch like nothing happened. It's not gonna be a good situation. So we're responsible for each other, and there are precipitating factors. What does that mean? With our patients, we not gonna always agree with them. They're not gonna always agree with us. But we're responsible for them to have a common goal to make sure they get what they need by us providing the best care, welfare, safety, and security to everybody that's involved. Our patients have person-centered and trauma approach. They have a lot of trauma going on. So how should we respond as staff? Recognize that the person knows themselves best. I cannot tell John that he's not in pain. If John tells me he's in pain, I can't tell him he's not, because he knows his body more than I do. We got to make sure that we allow our patients to tell us what's truly going on with them. If you missed the memo, put your cell phones on vibrate, turn them off, and put them in your pocket. Let's talk about cell phones too, while we're here. If we're providing the best care, welfare, safety, and security, I want you to think about this. If you're in the ER and you're sick, in the middle of your examination, the ER doctor stops talking to you and picks up his phone and just starts talking like you're not there. We often have situations with our patients that occurs. When it happens, it kind of throws the whole day off. If that patient has an issue to deal with, they don't want to talk to you anymore, it messes up the rhythm of the rapport. So it's important that we be mindful with these cell phones. Why? Because there are precipitating factors that happen in our patient's life that we can't control. For example, if I'm patient A and I was beaten by my father with a cell phone or a house phone as a child, and you pull your phone up while I'm trying to tell you something that's really impactful and something I need to get out, I'm going to have some feelings about that, and I'm going to respond a different way with you. I'm going to get into a little bit more of that in a second. Consider the person's life experiences. We only know what our patients tell us. How often the patients tell us their whole life story, and then we find out when the therapists get with them, that story changes a little bit. We got to be mindful. We got to consider the person's life experiences. Understand that every person is unique. Nobody's going to like to eat red beans like me. They're just not going to like it. So the patient's going to fuss, well, I don't like the food in the kitchen. But just eat it. But no, they don't like it. There's another option for you. We can choose to eat a salad. Value the person's right and dignity. Often we want to tell the patients what they need to do. We have to value their rights and their dignity. And I will say this, our patients know their rights probably better than we do. They'll tell you quick, I saw that, that's not in the handbook. That's not in the handbook. No, that's not what it says. I think today in community, we had some issues that came up, and I can guarantee you the patient's gonna come and say, I didn't see that in the handbook. I didn't see it in the handbook. So we want to value the person's dignity and their rights. Understanding of distress behavior. All behavior is a form of communication, and distress behavior can be how a person communicates their distress. Think of a person that's here right now. A person that's here right now. And knowing this, how does this change your approach to their challenging behaviors? Here's an example, and this is a question, this can be interactive, we can talk about this. But there's some patients here that act out. Do we ever think about what type of distressful behaviors they have and why they're acting out? Because often we will say, oh, that's just Jared. Y'all know Jared do that all the time, but why? Why does he do that? And how do we respond to that distressful behavior? Leave me alone. Why are you here? You could just leave if you want. It's a volunteer program. Those statements become challenging statements. So we got to be mindful. And what does that do? That puts us in a compromised situation safety-wise. If that patient is having some feelings about what you said, we've elevated the situation, and now we put ourselves in a situation that may not be safe because we've escalated. Does that make sense? That doesn't happen at this facility? I'm keep going. All right. What are some distress behaviors that you see here? That's anybody. What do we see? You don't have to call a patient. What do it look like?
Shouting.
A patient gets mad. They're shouting. Cursing. Huh? Refusing groups. What else? Slamming doors. Walking out. What about this one? Lying. Lying on staff. Lying on their peers. So we gotta know what that looks like. Why is that important? If we know what that looks like, then our responses will be different. We'll be able to approach it in a non-judgmental, in a calm manner. I will say this, there are times that the patients have us, well, our anxiety is so up, we gotta settle down first before we can respond to those patients. But if we know what it looks like, it helps us to deal with them in an appropriate manner. Understand the behavior and the risk. Man, that didn't come out too good, huh? There's low risk, high risk, medium risk, and extreme risk. This is something that was added about extreme risk. Here's a question: if there's a code, code white, house 5. No, let me use house 6. That's what I'm gonna do that. Code white right now. Code white, house 6. Where is the risk right now? Is it low, medium, high, or extreme? If we're in this room, what do we think?
Extreme.
Extreme, right?
Yeah.
We thinking extreme. Now, we've been over that forever. It's extreme. It's extreme. All right. So we leave it out. We leave out of the room. We enter the door where Bronson is. We exit there, and we headed to house 6. What could we do to lower the risk? We hadn't gotten over there yet. Run fast, call for help. We running over there. Who said that? What you said? Talk to the patients. But I'm glad you brought that point up. We hadn't made it there yet. But as we go in there, we are talking to the patients. So we want to minimize the risk. So it was extreme, now it's high. How can we get it to a medium risk? We're getting close. What could we do next? We walk in the house. We recognize that they already separated. So now we're at a medium risk. So we started here as an extreme risk, which we should. Every one of them we should. But as we go into a code, we should be examining the risk before we get there. Why is that important? Because we've been in house 6, house 5, house 12 for a lot of days. And our thought process is somebody may be fighting, but that may not be true. So if our approach going in is that they're fighting, then that changes our level of involvement, and we may be doing too much. So as we go in, we recognize that we had a medium risk. The patients are separated. What can we do now to lower the risk? Remove the patients from the scene. Get them away. Maybe bring someone outside. Have somebody else to go in the room. It's our job at all times to lower the risk. I use this example very often. When EMS gets here, it's extreme risk. They come in with lights on, woo, woo, woo. When they pull in the gate, it seems like they take 5 minutes to get out of the vehicle because they're examining the risk. Here's the next thing they'll do. Where are they? Who are they? Hey, what's going on with them? What's the blood pressure? Is a nurse with them? Blah, blah, blah. They are lowering the risk. And I don't know if you all noticed, but before EMS touch any patient, they do all this. They lower all these risks before they give them an ID, check their blood pressure, check their O2. They lower the risk. Why? Because they don't want to make the wrong moves. So our patients are expecting us, when we respond to codes that I'm going to get into in a moment, when we respond to codes, that we lower the risk. We got to lower the risk. If we don't lower the risk during the codes, we elevate the code. So we got to lower the risk. Yes, ma'am, go for it.
Also, when we're separating the patients in a code white, especially, we need to try to seek privacy. Like, it doesn't mean you just separate the patients and stand on the sidewalk with one while they've got an audience of other people around them. You want to be in their room with them with no other roommates, or taking them to the office or whatever, because that gives them privacy, gives us more calm to deal with things, but also they don't have an audience to grandstand in front of.
Correct. And the patients, they will get defensive. I'm pretty sure we've all seen that before, right? So if a patient curses us, we should curse them back. Y'all looking like y'all had to think about it. We should not be cursing. We should not be cursing our patients back. But they will become defensive. So how do we respond? Keep our answers short and simple. Stick to the topic. Provide choices for them. Provide choices, not demands. John, stop doing that with your hand.
There's no choice.
That's no choice for John. That's a demand. You don't have to stop, John. Here's one that we struggle with a lot. Allow that patient time to vent. Oh, he yelling and screaming, he cursing me out. Allow that time for that patient to vent. Sometimes they just need to vent, and then they settle down. No, don't say that. I'm not gonna mess with you, John. Don't say that, Jared. No, Jared. Jared, that is enough. Enough, Jared. Well, maybe they just need to talk and get it out. However, we need to try to isolate them so they can vent and not have this big scene for everybody. Provide time to let the person process it. Assess the level of risk and call for help if needed. I want to talk to you about rational detachment. We have to be able to say, and we do this a lot, Shayla, I cannot talk to patient such and such today. I need you to talk to them for me. We got to know that it's okay to let somebody help us. There are some patients, I can tell y'all, Mr. Patrick, I'll use him for an example. Mr. Patrick, when he first got here, he talked. That's all right with me. Until I start setting some limits on Mr. Patrick. But I took the conversations, so y'all don't have to give the conversations. And I'm pretty sure there's some patients that y'all took the conversations, so I don't have to give the conversations. But we have time where our patients, they get a little bit over the top for us if we're having a bad day. It's okay to ask for help. It's okay to ask for help. Now, I want to make some clarity with that. It's not okay to tell people, to have people to do your job. It's okay to ask for help. Because we all need help. Sometimes we gotta back out. But we need some help. Any questions about that? All right, let's talk a little bit about codes. On the back of your name badge, there's all the codes on there. And I'm gonna start at the top. With code red, there's a fire. This is our month for morning drill, so it's coming. If you are brand new hire, get with me right after so I can get with Casey to change your name on this list. But we need your phone number and answer the phone if we call you. Don't put us on Do Not Disturb. I found that out. You got to call it twice. You got to take off Do Not Disturb. Figured it out for my 17-year-old. But everybody on here, we will call you, and this is definitely going to come into play for our hurricanes. This is not the sheet, actually. There's a sheet that everybody has. Last month, I passed out a bunch of sheets and put them on the desk and employee support. If there's a fire, we should go to the fire first. Every building has a fire extinguisher at the exit. Grab a fire extinguisher, go to the fire first. This code, normally when I set them up, I'm looking to see if somebody, how long it take you to get there? Does someone have a fire extinguisher? And then we go and check our houses. Our spot that we collect is right here on the basketball court. We will call names, make sure everybody's there, make sure all staff is there. If you go to lunch, it's important that you let us know that you're going to lunch, because if we have a fire, we're looking for you. If you're not here, we don't know you're going to lunch. We're going in the building. Fire department's going to be going in the building and look for you to make sure you're safe. So please make sure you let us know when you're going off campus. In the houses, we want to make sure we keep the doors closed. Kitchen, turn the fire off, close the door. Leave the doors open, the fire spray real fast. Any questions about code reds? Because it's going to happen. It's going to happen soon. Y'all hear me say this often in staffing. Keep your walkie-talkies on. It's happening. Code white. Anytime we have any combative situations, we call the code white. Who should respond to that? Should we be walking to that? We should be trying to get there as soon as possible. Here's the deal, y'all. Whoever has the best rapport of that situation, we should be paying attention to them. How we know they have the best rapport? Because they're going to be the closest to that patient, talking to them, probably touching on them, and we should be watching them. They're going to give us cues. We good, or go, big eyes, like wait, but we're going to have these cues. Once we have cleared the code, don't just stand around and watch. The more we watch, the more audience the patient have, they act out. So go ahead and try to get the patients away first, and then we try to clear the scene. If there's a code blue, who responds to code blue? Everybody. Once the code blue's called, we get there. Normally the patients are going to be there before us, and they're going to be nurses and doctors before we get there. You already know that. But once the nurses arrive, we need to let the nurses give us direction on what to do. And if you hadn't been through this before, you're going to hear it's a lot of chatter. Hey, this such and such, go do this, go do that. Hey, should we be calling 911? Get the wheelchair, open the gate. Is the gate open? It's a lot happening. It's a lot happening in Code Blue. Once the nurses get there, the nurses are going to tell us what we need to do. For example, I think I asked Amanda this a couple months ago. There was a patient, I was unsure. Should we put him on the ground or should we leave him up? Like, what to do? Once the nurses get there, then they know what to do. If the nurse directs you to do something during a Code Blue, that's not the time to ask questions. Hey, Julie, why are we doing this again? Well, we have a potential patient that can be really, really ill. Follow the nurse's direction, and they're going to let us know where we go from there. If you are here where it's not as much staff, that needs to be someone at the gate waiting on EMS to direct them It used to be where we kind of knew who was coming, the fire department, we knew who was coming, but now it could be anybody. So we want to make sure we direct them to the right place. Green charts. Who should respond to green charts?
Leadership.
Leadership. What are we looking for? We looking for a thumbs up, a come in, a hold on, and we'll wait. We'll wait. If leadership is taking too long because we're in administration and we're in a meeting, what can we do next? Call the full code. Get some help over there as soon as possible. Code gray, tornado warning. We've had a bunch of them. We will probably in the next couple of weeks start getting more tornadoes and all that good stuff. We want to make sure that we get all the patients out of the residential trailers, marginals, and have them go into house 10,
No.
not 10, 11, 3, 1, 2, and 12 here in the therapy center. We've been real good with that. It's working well. I think the patient's finally catching on. If we say you need to go, then go out. Code black, a bomb threat. Should we use our cell phones? No cell phones. No cell phones. Make sure when that call is made that you're not texting, you're not calling home and saying you got a bomb threat, because your phone actually may be able to make the bomb go off. Be careful of that. Here's the last one. Code silver. We're going to practice this. There's a lot of chatter on the walkie-talkie when we have code silver. The shooter's walking down the basketball court. He's doing such and such. Grab your patients. A lot of them have earbuds on. If you can, grab your patients and find you a hiding spot. Code silver, I noticed this in the last code. That is not the time to be nosy.
Yeah.
Find your patients, find your spot, and go hide. Go hide. I'm gonna tell you there's gonna be, if I'm here, just know you got one nosy person, because I'm gonna be nosy. But y'all hide. Go hide and make sure you grab a patient. Now, I do know this. In pressure situation, you might say, well, I ain't thinking about grabbing no patient, I'm gonna grab them. Yes, you will. Your caring nature is gonna tell you to grab that patient and take them with you. We talk about this, why are you looking at me like that? we talk about this and go over this with the patients too. Hey, we're responsible for you, but if there's an active shooting, you telling me I'm not going nowhere, then I gotta go hide. But the patients, we going through this with the patients, so they know too. If there's a true situation, we hope that they respond in an appropriate manner. The last thing, incident reports. Incident reports, y'all, we struggling. We're better, but we're struggling. If you see something happens, this incident report does not bound you to any liability. This is letting us know that there's an incident that occurred. This is what happens. At that point, it goes to the nurses, they assess it, it comes to me, it goes to Sally. We've had this year, I think 3 incidents, that we didn't know anything about. But here's the problem. The patients say, well, Juanicia saw me fall. She didn't tell you? So we go back and talk to Juanicia. Oh yeah, they fell at 7:30. They slipped on some milk. But she didn't do the incident report. But guess what? That patient's going to include you. So put your name on here. So if you see it, write it down. Now, we do know this, because me and Amanda went through this last week. The patient said things that happened that we never saw. All we write is what that patient says. On this bottom portion, we're going to ask that you be real specific. If they say that I slipped because my shoes were wet and my back came off, we need you to write that. We need you to write exactly what that patient says. This form is for our records, so we'll know what's going on. But it's not your job, and it's not that patient. Don't let them force you to think that you have to make a determination about what happened in that incident. All you're doing is documenting. We go back and forth. Nurses, me and Sarah and Jess and Sheila, we go back and forth about, well, no, it can't be. But we're going off what you write. The more you write, the more detail it is, it's less likely we're coming back to you.
So,
But we-
so if it's something you saw, you state what you saw.
Yeah.
But if it's something that a patient reports, you say patient reported, patient stated. So right there, you're saying, I didn't see it, I don't know, but this is what the patient is reporting. And that's
Yep.
all you can do.
Yep. On the back, it asks what type of injury, fall, slip. If you're not sure, that's a nursing question. Hey, what do I put here? A lot of times, if we ask the patients, they'll tell us what they think, and we'll have that. One struggle that we have, especially with the nature of the injury, if that patient break a bone, we're not doctors. So we can't say that that patient broke his left arm because we're not doctors. Now, if a nurse may put that possible fracture or possible something, but a lot of times we see, they broke their finger. I think they broke their finger. Well, we gotta be careful with that. All we can mention is that there was a portion of the finger that seemed to be bruised. Something didn't look right.
Dislocated.
Yeah.
Hanging at a right
Yeah,
angle.
just be mindful of that. At the bottom, if someone falls, it was raining in here, and you see someone fall, please try to clean it up as soon as possible. Clean the water up. Also, put a caution sign down so that nobody else get injured until we can deal with the situation. That happens a lot. If you see an incident that happened and you can do something to prevent it from happening again, please do so. Also, if there's something that's not safe, please don't wait till the next staff meeting to tell us about it. We need to know about it as soon as possible so we can fix it. We want everybody to be safe, and we want to be safe. Any questions? Comments? Yes, ma'am.
Who's responsible for initiating the incident report?
Good question. The person that sees the incident should be filling out the incident report. I know. I gotta do another piece of paperwork, I know. But, y'all, this incident reports have to be filled out. If you don't do it, then Amanda will end up doing it, or Julie, or Cindy. They gotta go through the nurse, Rihanna, Precious. It gotta go through the nurse, it gotta come through me, it gotta go through Sally. We gotta get an incident report. Please, if you see something, please write the incident report. I can tell y'all this quarter, it's been way better. Still a struggle, but it's been way better. And we appreciate it. I can tell y'all this, there may be something that comes up 8 months from now that we don't remember. But if we can go back to the incident report and read it, along with the tech report, we got what we need. It helps a lot. Yes, ma'am.
And then if you didn't see it, but the patient came and reported it to you, you are the one to write the incident report.
Yeah, you initiate the report, they tell you, and also it's okay to write patient stated. Patient stated, I fell out the bathtub 2 weeks ago. You didn't tell nobody. Patient stated he didn't tell anybody. He signed a refusal of care. Yes, ma'am. Same thing? All right, cool. Anything else? All right.
The refusal of care form.
The refusal of care forms, I didn't bring one. The refusal of care form and the incident reports go together. Often we see the refusal of care form with nothing, so we don't know what happened. They go together. I want to say this too. A patient can refuse today, right now at 2 o'clock, and then say they want to go to the ER at 6 o'clock. That's their right. That's okay. That's nothing wrong with that. But initially, if that patient's telling you that I refuse treatment, have them to sign a refusal of care form at that time. Good questions. Yes, ma'am.
For every incident report, should there be a refusal of care? Or
For
is
every
it
incident report, we should ask that
If they
patient.
did.
We should ask that patient, do you require any further assistance? Would you like to go out? Depends on what's going on too. But we need that to be presented to them. Yeah. Yes, ma'am.
So what if they refuse care 10 days for you to go out the next day?
There's nothing wrong with that. Yeah, that's okay. Yeah, that's okay. Then that's another good question. Let's use this whole flu virus season for 2 days, we might be feeling fine, and then day 3, we say, we might need to go. We might need to go. So we do the same thing. That's okay. They can refuse. Well, I'm just about done. Yeah. Yeah. All right, y'all. We got some snacks. Enjoy the birthday.